Hi everyone, I'm Elliott. I'm one of the physios who's come on board at Second Nature Football. So I thought I'd just get started by giving you a little bit of background on who I am and what I do. So first and foremost, I'm a Liverpool supporter, born and bred. Really hope that we can come home strong for the back end of the season, but we'll see. Now, I played football all throughout my school years. I was a right winger, and I had this pretty much the strongest part of my play was I had this monster throw in. Whenever the ball went out in the opposition half, it was always an attacking option to have me do a nice big long throw. I did my Bachelor of Sports Science and then a Master's in Physiotherapy, both at the University of Sydney. I work at a private practice. Currently, I'm in North Kirkhill, but I've worked at some private practices in Western Sydney and in the North Shore. I've been practicing for a bit over 5 years now. As you can see in that photo, my main sport, where my passion for sport and even injuries to some extent came from was I was a competitive javelin thrower for a number of years. Ended up having an elbow reconstruction, qualified for the Commonwealth Games, and then was staring down the barrel of a shoulder reconstruction and ended up having to retire as a result of that. But what that kind of taught me was a lot about, how injuries affect you, obviously physically, but also mentally, and how you juggle that with, your sporting career and even your social life as well. So just to get kind of a bit started just with the basics of physio. So the current definition is that we provide evidence-based treatment to restore, maintain and optimize mobility, strength, function and just overall general health and well-being. We have a number of tools at our disposal on how we work to improve those things. So the biggest one is probably just education. So teaching our clients about their pain and their injuries and, the ways that they can improve and adapt and overcome from those. We also use biomechanical analysis to kind of dive into the depths of what could be causing that injury. We obviously perform physical rehab, so, prescribing exercises, whether it's kind of strength or mobility or plyometric. We do a lot of pain modulation. That's probably what most people associate us with, the elbow into the glutes and the massage and the dry needling and all that sort of stuff. So we are, generally trained quite well in helping to reduce pain. And another big one, especially in sports physio, is injury prevention. So how well can we reduce an athlete's risk of, a knee injury or a hamstring strain through exercise mostly. And probably leading into that point, we do work as like a cohesive unit with, everything from the coach of the team to the S&C trainers, massage therapists, doctors and specialists. We're part of that kind of holistic care that really gives the athlete, all the support they could possibly need to get the best outcome. So I thought I'd just kind of put together a bit of what you would expect in a consult with a physio or like meeting your club's physio. So obviously tell us about your injury or the pain that you're currently experiencing. You'll probably get prodded and posed a whole bunch of questions based off, as I've said there, age, gender, what sport you're playing, your current training, other aspects of your life, such as, sleep, if there's any major stresses, if you're on any medication, that all kind of forms a really important kind of overall picture of your current health and well-being, and can give us little clues actually as to kind of what's going to be contributing to your pain and your injury. We then dive into the history of that injury and also previous injuries that you may have had, and potentially even trying to think of ways that, you know, an ankle sprain has potentially then caused an overload of the calf, and then the calf is overcompensated and become torn, just as an example. We'll obviously question you on the symptoms. So is it sharp or dull pain? Is it all the time? Is it only when you're doing one specific part of your game? You know, all sorts of different kind of characteristics and, you know, the peaks and troughs of your pain can be quite helpful once again for working out that diagnosis, which is, you know, super important to get your management and your plan of attack spot on. Yeah, and obviously we'll ask you a couple of questions about, you know, what you've been doing to manage it so far. Like if you've seen another physio or a chiro or a doctor, you know, what they've told you and the things that you've tried before that, you know, may have worked a little bit or may not have worked or could have even made you worse. Like that's all really important to figure out what's going on as well. You know, then after we've kind of had that discussion, you know, what people would really kind of associate us with is our objective measures. So, you know, we're kind of looking then at how your body moves and how it performs under pressure. So what its range of motion, its flexibility is like, your strength, if there's any kind of imaging or video analysis that we can look at, you know, that all is then really starting to feed into the picture of all the history and the background that you've given us so far just by telling us. And we usually try and actually aim to have a pretty good idea of what the injury is before we even get into the hands-on assessment. You know, so if you come in and say, you know, I was running down the sideline and someone knocked me, and I kind of put my foot out to steady myself, and there was a sharp pain on the inside of my knee. The follow-up questions that I'm asking are then going to be trying to sort of figure out, okay, well, the pain's on the inside of the knee, what structure are we looking at there? And then I'm looking to just confirm that with my objective assessment. So, you know, if it's imaging or like where exactly you're sore, or if your strength of the knee has really reduced, that's all going to give me a really good idea on what structure you've injured, how severely you've injured it, and then obviously what that means for your treatment. So that kind of leads into your hypothesis. So what's our most likely diagnosis? You know, and then I'd like to break treatment up into like the active and passive aspects of it. So the active treatments, you know, your strengthening exercises, your mobility exercises, you know, your stretching, you know, your core work, your balance exercises, all that really forms a really good kind of long-term, you know, approach to getting you better and also keeping you better. And then once again, the passive side of things is then, you know, the hands-on work that we do with, you know, massage, dry needling, joint mobilization, you know, the old school stuff, you know, even like a good old ice pack or a heat pack still has some merit for pain relief mostly. So the big question and where I'm kind of wanting to go with today is, when should you come and see us? At what point does an injury get to the point where, you know, you're having to then come in and see us for an assessment and some treatment? So, you know, I've kind of broken these injuries into acute and subacute injuries. And I've broken them down into like their characteristics and what they kind of mean for your management. So, you know, as I was saying, if you're running down the sideline and you cop a bit of a bump and you put your foot out, is that a contact or a non-contact? I'd probably say it's more of a non-contact because you've put your foot out to stabilize yourself and you've got a pain in the knee. It's not like someone knocked you in the knee or you got a studs up challenge mid-shin. That's a little bit more obviously a contact-related injury. What was the mechanism? Did the knee twist? Did it buckle? Did it hyperextend? All those feed into kind of what we're thinking diagnosis-wise. We're then looking for stuff that you're describing symptom-wise in terms of clicking or clunking or losses of strength or power, or you're just not feeling like it's stable. And then the other big thing that we do is obviously head injury assessment. So if there's a head clash or, a knock to the head, or even if you've kind of fallen and your head's hit the ground quite hard, we're kind of that first line of defense to make sure that you aren't continuing to play and potentially endangering yourself and the people around you. And then, your short-term management. The most accurate assessment that a physio can do is actually straight away on the field. Especially for ligament-related injuries, getting in and actually testing the structural integrity of those ligaments before pain and swelling have really actually had time to take their hold. So that on-field assessment is so important, especially for knees mostly. That then gives us a rough, hopefully, diagnosis, which then actually informs then your prognosis. So how long is that injury going to take? If I think it's a grade 1 tear of your hamstring, studies have shown that grade 1s usually have kind of like a 1 to 3 week recovery time. So, even just telling the client that that's probably what we're looking at can provide a lot of reassurance and get rid of that kind of fear of the unknown, being able to give it a definitive or a rough guideline in terms of how long this is going to take. The short-term stuff that we do, we can strap it, we can put it in a brace, we can put an ice pack on it or a heat pack, or, give you some anti-inflammatories or some pain medication to help to reduce that. And then a little bit further down the line, potentially even refer you off for, a scan or even to a specialist if we deem that's necessary as well. So then with your non-acute injuries, so these ones are usually a little bit more tricky. So these are the ones that don't have that obvious kind of sudden onset of pain. It kind of is this niggly thing that builds up over time or might even come and go. You can have days where you do the exact same thing and it's fine, and other days where you do it and it's quite sore. There's no obvious onset. It builds up gradually. It can be on and off. It could be potentially not even a specific location. You just know that the pain is like roughly in your ankle somewhere, but you're not quite sure if it's slightly towards the front or at the back, or exactly what it is that you're doing that is setting off that pain. The big things that we look at are if there's any evidence of like a spike in your training load or your load overall throughout the week. So what we're seeing a lot of at the moment is, as people kind of get back into their training after the summer holidays and, a bit of time off, and they just think that they can easily slot back into that intensive training that they were doing before. And the body just unfortunately does need a little bit of time to readapt and readjust to that. And if it isn't able to adapt in time, that's when we do run into these overuse related injuries as well. So with that in mind, our most common treatment for that sort of thing is just load management. So reducing your load or adjusting your load accordingly. If you were doing 2 runs over the Christmas period as your training, and now you're doing 3 training sessions with your club, 2 training sessions with your school, and a game of each on the weekends, we might just have a look at and a bit of a chat about, maybe dropping or reducing your running in a couple of those sessions, just to allow things to adjust and adapt over a little bit more time. We can kind of shorten that adaptive phase, through the use of like strengthening exercises, mobility exercises, making some adjustments to your technique, potentially depending on what the injury is and what we think is causing it. And once again, our pain relieving techniques. So, our massage, our dry needling, they've all been shown to be quite good for reducing your pain in the short term. And, if we can use that to then facilitate some more exercise or getting you back into training sooner because you've got less pain, that's going to be better for everyone involved as well. So on the topic of pain, I kind of wanted to address this today just to give you a bit of an understanding as to, what is pain, what causes it, and what are the factors at play that are actually contributing to that sensation of pain that you're having. So, as you can see, pain is generally described by an unpleasant sensory and emotional experience unique to every individual and is associated with actual or potential tissue damage. And the really important part of that definition is actually the potential part. We obviously know that, when you stub your toe or, you walk into a table, there's obviously going to be pain that is associated with that. But where the pain science has really changed over the last decade or so is our understanding of, what is it with these people where they might not necessarily have anything physically wrong with them, like there's potentially no damage that's occurred and no structural thing wrong with them, but they're still in sometimes like quite severe pain. And what's the science behind that? And what does that mean for, the athlete that rolled their ankle, but their ankle's still sore 6 months later? And on the scans, all the ligaments and the tendons and the structures there look completely fine. Why is their ankle still sore? And that leads into the next dot point, where pain is like an alarm. So it's usually useful if there is to protect us, but can also become hypersensitive or even malfunction due to other factors, which we'll touch on in a little bit. The analogies that I like to use, and Travis actually popped one of these up on his Instagram earlier this week, about the use of calluses versus blisters. Why are calluses adaptations to skin that aren't actually sore, and it's just a hardening of the skin on your hands or on your feet? But blisters, on the other hand, it's the exact same thing that caused it. It's still damage to the skin, but they're painful. Why aren't calluses painful? So the analogy, I don't bruise that easily, but I've seen some people that, will just look at a side of a table, and next thing you know, they've got a bruise on the side of their thigh that's quite big. And half the time they actually couldn't even tell you where they got those bruises from. So bruises are an obvious sign of some sort of damage that's occurred, and actually like internal bleeding that's occurred under the surface of the skin. But why is it that they have no idea or recollection of how they got it? And, you've obviously had an injury, but it hasn't been painful. So that's a really important question to ask. Sunburn, for example, I get sunburn all the time. And, it's sore, obviously, due to the damage to your skin that's occurred from laying out in the sun for too long. But why is it when we go and have a shower, hot or cold water, why is it sore when we stand under the water in the shower with sunburn? There's no damage that's actually happening to the skin when we stand under the stream of the shower, but it's still painful, even though there's no actual damage occurring. So it's more the potential tissue damage there that's contributing to that. And lastly, paper cuts. They're small, niggly, annoying things that are caused by a piece of paper, but if you've ever had one, they really hurt like hell. And part of that is actually due to like the mental association, the real negative experience that we're almost taught to have due to, we see paper cuts happen on TV and in movies and that sort of thing. And we're almost expecting paper cuts to be sore because we're told that they are sore. So a little bit on kind of how pain actually works. As you can see on the left side of that image, the 16th century approach was a very one-dimensional, one-way street approach to how pain works. So, you put your foot in a fire, that triggers a nerve in your foot that then sends a signal up to your brain saying this thing is causing damage to my foot. And that is how they used to think that pain worked, which kind of on principle or at a glance, you'd say, yeah, that makes sense to me. But as we're beginning to understand, pain is a little bit more complex than that. So the image on the right, as you can see, there's actually a two-way stream that happens there. So, your foot goes in the fire, and it activates something called like a nociceptor, which is like a pain signal that then shoots up your peripheral nervous system up through your central nervous system into your brain. And then your brain actually has to interpret that information. So it's kind of taking all these other factors into consideration there where, if you've put your foot in the fire before, or if you're expecting yourself to put your foot in the fire, that would actually have an effect on how intense the pain that you actually are going to experience. Studies have even shown things like your mood. So if you're stressed or anxious, or you haven't slept well, or you're expecting the pain to be lasting a long time, they can all actually have an effect on how you process and interpret that pain signal. And then where the two-way street comes in is actually your brain has the ability to actually up-regulate or down-regulate that pain signal, that pain response. So your brain has the ability to go, yeah, I know that signal's coming, I understand that, but it's safe, I don't care, I don't mind. Foot in the fire is probably not the best example there, but if you're running a marathon and you're in the last couple of Ks and your calves and your quads are just screaming at you going, I'm in so much pain, like where's the finish line? Your brain you're able to interpret that information and adapt it to what goals you have in mind. So that's your ability to down-regulate. And then up-regulating is kind of where we come in. So going back to that analogy where, you've rolled your ankle and 6 months later it's still sore. And we know that there's no structural damage or anything physically wrong with the ankle. But your brain, for some reason, is still picking up on or heightening the pain signals or the pain responses from the ankle. And sometimes the pain there's no pain signal coming from the ankle at all. It's all actually happening or processed in the brain. An example of that would be, people with, let's say, like phantom limb pain. So these are people where they're an amputee, they've lost their hand for whatever reason, but we still have reports from those people that they feel itchy or pain or some sort of negative experience in the hand that isn't even there anymore, which is pretty crazy when you think about it. And this next slide kind of touches on that a little bit further. So as you can see, there's all these different factors that can contribute to how your brain processes that pain signal. So, everything from your sleep to your current emotions to previous experiences that you've had to what your friends have told you happens when this sort of injury occurs, what the doctor said versus what the physio said. That uncertainty can all contribute to actually making your pain feel better or worse, depending on what those inputs are. So you can, where we come in is we try and almost build a really supportive network of reassurance and understanding that enables us to down-regulate and kind of understand and control our pain a little bit better. So look, just to kind of follow on from that, where probably our understanding of your rehab program then goes from there. So I like the SPORT acronym, so keep it specific. So it's got to be, relevant to your sport. A footballer, for example, they are, as Christian touched on last week, around sort of, 5 to 10% of their running is actually those short, sharp bursts of sprinting. I think it was less than 200 meters in a game of 90 minutes is that really kind of short, sharp sprinting. So, even though that is a very, very small proportion, that is where we see most of our injuries occurring. So there's not much point in us doing these, slow, loaded exercises where everything's really under a controlled, slow setting. We need to have an athlete that is ready to go, can do these explosive movements with agility and balance all in one go. So we need to progress it appropriately. We can't throw you straight into the deep end with that stuff. We've got to build you up to that slowly. We need to overload to elicit an adaptation or a response from the body to get stronger or to get fitter or to get faster. It has to be reversible. So if we go a step too far and we push it too hard, we need to be able to regress you and to make that easier so you can readjust. And then obviously time. So how long is it going to take and how long are we expecting you to take with that? So, it's kind of an oversimplification there of a rough rehab program or a generic rehab program. And you can see the flowchart there if you're wanting to do a bit of a DIY job on your rehab. I wouldn't recommend it, but you can give it a go. It's pretty much just picking something that is relevant and specific to your injury and your sport. And if it's not painful, just kind of simply progressing it and building it from there is a pretty good place to start. So look, just to kind of summarize, in general, the way that we really help to manage pain is building confidence and reassuring people with movement. So if you've had a fractured ankle and you've been in a boot for 6 weeks, and we get you out of that boot and it's stiff, it's sore, it's still swollen, we know that the structure, like the bone, has had the chance to heal. So we just slowly start to implement some exercises where we're getting things moving, getting you comfortable with that movement and going from there. Start low, go slow. So that's kind of where we would start, not even with weight bearing. We'd just start you with something super easy and build you from there. But pain shouldn't be feared completely. Pain can be helpful. So, push into pain generally if you're confident in doing so and it's feeling safe. If it's done at a tolerable level, if the pain that you're experiencing during the exercise doesn't last for too long afterwards. And a big one to kind of push into pain a little bit is if you've been avoiding doing the thing that hurts and that just simply hasn't worked for you so far, that's usually a pretty good indication of, you need to change something, you need to adapt. And then pretty much the complete opposite of that is when you should be avoiding pain. So if there's any serious pathology like a broken bone, if it hasn't had time to heal, so if you broke it 3 weeks ago, we know that the bone is probably still not structurally sound yet, so you shouldn't be doing much on that bone at all. And then the opposite. So if pushing into pain is what you've been doing and it hasn't improved, it hasn't got better, or if anything, it's gotten worse, that's pretty self-explanatory there. Just to finish with a quote, challenge the pain barrier, don't push through it. And doing this can actually help you move that pain barrier. So to actually make things painless or less painful, that's always a good place to start. So look, that kind of finishes the content for today. I'd like to now open up to if you've got any questions or queries, anything that you want to pick my brain about at all. I'll be hanging around for the next, 5 minutes or so. And yeah, more than happy to answer any questions that you might have regarding physio. If you've got an injury yourself and you want to pick my brain, just, shoot a message through. If you're unsure about anything I've touched on, feel free to just shoot a message through. More than happy to talk about it in the chat or online. So I'll just give you a couple of minutes if anyone wants to shoot anything through. Something. Okay, so how long on average would it take for treatment to show your results and improvements after injury? Really good question. Look, it really kind of depends on the injury. So as I was alluding to before, we know the rough healing times for certain injuries. So like a grade 1 muscle strain is 1 to 3 weeks. Grade 2 is kind of 4 to 7 to 8 weeks. If it's a tendinopathy, we know that they can take a little bit longer. So we'd be expecting like an 8 to 12 week turnaround. Broken bones, 4 to 6 weeks. So we kind of base our treatment plan and our schedule off that. So we know, a hamstring strain, it's going to be 3 weeks before you're back to sport. Week 1, we'd expect this to happen. Week 2, we'd expect this to happen. Week 3, we'd expect this to happen. And if we aren't getting the results that are expected, it keeps me accountable, or keeps the physiotherapist accountable, because then what you've said it is and what is happening are two very different things. So yeah, I hope that answers your question. It actually more depends on the injury, the type of injury, and what the treatment plan is. Are we trying to build strength? Are we trying to improve flexibility? Are we just wanting to restore and build up load? So yeah, long answer, but pretty much it depends. So Chris has asked, I've got heel pain and people say it's growing pains. What do I need to do? Look, a couple of big ones that we do see, especially in like growing, I'm not sure how old you are, Chris, but we see something called like Sever's disease, which I guess you could class as a type of growing pain. A lot of that would then, if it is Sever's, then I'd probably recommend you to see a physio to make sure that it is what you think it is. But a lot of Sever's management comes down to actually load management. So having a look at how many sessions you're doing per week, how much running you're doing in each of those sessions, and actually seeing if we can just modify and adjust your load to get your pain down to an acceptable level. Growing pains, you're growing for a certain period of time, the growing pain will go away. But in the meantime, to make sure that we don't cause any permanent damage to that growth plate in your heel, we do need to manage your load. So once again, long answer, but probably heel pain could be any number of things. It could be where your Achilles is inserting. It could be where your plantar fascia is inserting. And management for those kind of depends on what it is. So I'd recommend have a chat to your physiotherapist or shoot me a message, and I'm happy to talk about it a bit more in depth. But yeah, I'd be saying load management would be where I'd start with you if you were one of my clients. Hope that helps. No worries. Any other questions? But yeah, really looking forward to doing another one of these. I think next time I'm going to look at kind of some of the myths and things that we're told about injuries in physio that aren't true. And I think next week, Jared is going to be jumping on and he's going to be talking all things sprinting. So make sure you get onto that next week. Jared's one of the best sprinters, or was one of the best sprinters in Australia. So it would be really cool to get his input on sprinting.